Hello everyone, and welcome to the first part of this four-part lecture series on advanced MRI techniques. My name is Riham Dasuki. I'm an assistant professor of radiology at the Faculty of Medicine, Zagazig University, and today we will be discussing diffusion-weighted imaging. So what is diffusion-weighted imaging? Diffusion imaging focuses on the micro-movements or the random Brownian motion of water molecules inside voxels. This video demonstrates an example of this small micro-movement in random fashion under the microscope. What are the types of diffusion? So displacement of water molecules can be summarized into one of three different patterns or three different types. First type of diffusion is free diffusion, in which water molecules displace freely in all directions, and this typically occurs in fluids such as the cerebrospinal fluid. The second type of diffusion is restricted isotropic diffusion, and in this type of diffusion, the water molecule displacement is somewhat restricted, and this can occur in whatever of the three spatial directions by numerous obstacles such as proteins or cells. Examples of this is abscess, cellular tumor, and other pathological conditions. The third and final type of diffusion is restricted anisotropic diffusion, and this occurs due to certain tissue structures which can create obstacles that orient the motion of water molecules in a particular direction and restricted in the other. And a good example of this is nerve fibers, in which the direction of water molecule movement is usually longitudinal but restricted in the transverse plane. So let's see this in graphical form so it can be further clarified. Isotropic unrestricted diffusion, water molecules occurs freely in any type of direction. This will give a diffusion ellipsoid which is equal in all directions, since the probability of water is equal in any of the three spatial directions. The second example is where this diffusion is still random but restricted. This will give an ellipsoid or a sphere that is smaller in total direction and can be limited in any one of the three spatial directions. Our third example is where there is a coherent restriction of diffusion, such as in the axonal bundle, and this is the anisotropic restricted diffusion. This will turn the spherical ellipsoid into a somewhat elongated or oblong ellipsoid. Why this occurs is because diffusion is relatively facilitated in a certain direction, however, it is restricted in the other. So, how is a diffusion sequence acquired? A diffusion-weighted sequence is always a T2-based, either spin or gradient echo-planar imaging. The echo-planar imaging is used with an ultra-fast sequence in order to limit body motion during the acquisition and only acquire the random movement or micromolecular movement of water. Diffusion gradients are placed on either side of the 180-degree pulse. So what happens in a regular spin echo sequence is that we first give a phasing 90-degree RF pulse followed by a 180-degree pulse. So the difference with diffusion is that we put a diffusion gradient just before and just after this 180-degree pulse. What this does is depends on whether the spins are stationary or mobile. So let's have a look at what happens during the diffusion-weighted sequence. First, we give a 90-degree pulse, which aligns the protons, and then we apply our first diffusion gradient. The phase shift will depend on whether the protons are moving or not moving. If protons are moving, we give our 90-degree pulse followed by our diffusion gradients, and protons will start to dephase immediately because they are moving. When we follow with a 180-degree pulse and the second diffusion gradient, there will not be a complete 180-degree reversal. Why this occurs is because protons are moving, so they have partially dephased already. So when we give the 180-degree pulse, it will not be a completely inverting pulse. What this does is that it brings back a signal which is much less than the signal if the protons were stationary taking the full degree of pulse. Okay, So let's give the second example. When we give our 90-degree pulse, which applies the protons, we apply our diffusion gradient, but the protons are not moving. If protons do not move, they will take the 90-degree pulse and the first diffusion gradient. So when this is followed with a 180-degree pulse and a second gradient, there will be a complete reversal or phase shift of all the protons since they have not moved. Okay, what this returns is a signal intensity which is much brighter in comparison to protons which are moving, because the degree of dephasing of moving protons is much larger than the degree of dephasing in non-mobile protons. So when we apply diffusion gradients on either side of the 180-degree pulse, we expect a higher signal from stationary protons and a much lower signal from mobile protons. Okay, so let's explain what is the ultra-fast sequence and what is echoplanar imaging to understand why we use it with diffusion-weighted imaging specifically. Echoes are usually generated in the diffusion-weighted sequence using ultra-fast sequences, which either are formed by 180-degree rephasing pulses if we are using spin echo, or is this formed by a flip angle formed by gradient echo EPI. So this is an example of spin echo EPI. What we do is we give a regular 90-degree pulse. This will cause the alignment of the protons. Here we have T2 base of sequence, so there will be some T2 effect and some underlying T2 star effect. After giving the 90-degree pulse, protons will begin to dephase gradually. We follow this by a 180-degree pulse. And what happens is, to acquire the ultra-fast sequence, we keep giving smaller amplitude, less than 90-degree, rephasing and dephasing gradients in either side, okay, to continue taking the signal after the 180-degree pulse and to avoid the loss of signal from protons following this 180-degree pulse. So the ultra-fast sequence means that we give repetitive gradients which are not a complete 90-degree pulse or a complete 180-degree pulse, but they are enough to keep the signal going from these protons and acquire all the needed slices within the same echo time. What this does is that when we use echoplanar imaging, in addition to this ultra-fast sequence, it means that we acquire all the data needed and we fill the k-space within only a single echo train. So when we keep taking the signal from the ultra-fast sequence, we can also use echoplanar imaging to rapidly fill the k-space within the TE acquired. So what this does is it rapidly accelerates imaging acquisition with rapid filling of the k-space. So ultra-fast sequence is applied by giving multiple rapid gradients which keep the signal going, and echoplanar imaging also leads to a rapid filling of the information needed to form our complete acquisition from a single echo train, as we have just mentioned. Giving another example, but with gradient echoplanar imaging, it is exactly the same idea. We give the 90-degree pulse, followed by our flip angle. There will also be a free induction decay, which is the D2 star weighting. However, to keep the signal going, we will give our partial phasing and dephasing gradients, which will keep the signal going along the echo time, and we will also rapidly acquire all the information needed within the k-space. Of course, as we have already discussed in previous lectures, the k-space is the space or the virtual space within the MRI machine in which we store all the acquisition data. So as long as we fill the k-space, we have all the information needed to form our image. Okay, so this is what happens exactly with the echoplanar EPI. As we said, we give a 90-degree pulse. This will give us the phasing of the protons. And then we give our 180-degree pulse. And in order not to lose the signal, we keep giving partial positive and negative gradients, and this will give us multiple echoes within the echo time needed to acquire the image. Okay, so what happens when we put a diffusion gradient just before and just after the 180-degree pulse? This will give us a diffusion weighted image. So how about the degree of weighting? How do we know how much weighting or diffusion weighting is within this image? Each diffusion weighted gradient has an amplitude, which is represented as the G, a duration, which is represented as the omega, and a time interval between the first and the second gradient. All these three factors, when combined in a certain equation, will give us the degree of diffusion weighting, which is known as the B value. From here, let's discuss some important diffusion parameters, which are the B value and the apparent diffusion coefficient. As we just mentioned, the B value indicates the magnitude of diffusion weighting expressed in seconds per millimeter squared. This will depend on the amplitude, which we just mentioned is the G, the separation, which is the time between the first and the second diffusion gradient, and the duration, which is the amount of time each gradient takes just before and after the 180-degree pulse. So all these three factors are combined into an equation to give us the B value, or the magnitude of diffusion weighting. So what are the applications of B value? The B0 is the sequence run without diffusion gradients, and this is a T2 or T2 star weighted image, as we have just mentioned. The B600 to 700, which is the intermediate B value, is usually used in neonatal and body imaging. So why do we use intermediate B value in neonatal and body imaging? This is because of the inherent intermediate relaxation time of these tissues. So a suitable weighting will be an intermediate, not low or high B value. So when do we use a high B value, such as a B1000? We use a B1000 in areas with high organized tissues, such as the brain. So a B1000 value will be used for evaluation of cerebral infarcts. So B value is the magnitude of diffusion weighting and varies according to the application. In all cases, we give a B0, and depending on the area of the body we want to visualize, we give either intermediate B600 to 700 or B1000. So what is the apparent diffusion coefficient? The apparent diffusion coefficient is a measure of the actual diffusion, or the amount of diffusion within a certain area of the body and within a certain area of interest within the tissues. And this is expressed in millimeters squared per second. Different B values, either B or other higher B values, can be combined to calculate the apparent diffusion coefficient. So the apparent diffusion coefficient is actually a calculated map and not a true image. And we will discuss how this map is formed just now. The ADC applications is that we aim to remove the intrinsic T2 signal on which we based our diffusion weighted sequence. And the importance of removing this T2 signal is to avoid any artifactual increase or decrease in diffusion. Quantitative information can also be derived from ADC map, as the ADC map reflects the actual measure of diffusion within the tissue. How do we do this? We only draw a region of interest, and from this region of interest we can automatically calculate the mean apparent diffusion coefficient within the region of interest. So let's discuss how the ADC map is calculated. The ADC map, as we have just said, is a computation from a minimum of two images with different B values. For example, a B0 and a B1000 image. Higher B values impart more diffusion weighting because the magnitude of diffusion weighting increases with increasing B value. The ADC map is calculated by performing a pixel by pixel fitting of this signal intensity with increasing B values. So from B0, we have an almost T2 star weighted image with no diffusion weighting. With increasing B values, the diffusion weighting increases and the T2 effect decreases. But in all B weighted images, or in all diffusion weighted images calculated through B value, we have some degree of T2 weighting with increasing degree of diffusion weighting. If we plot the logarithmic signal of the increasing B values against the signal intensity coming from each B value, this will give us a slope of the curve. This slope will give us the diffusion characteristic of the tissue, but will negate any T2 influence on this image. Thus, this will derive an ADC signal. So, let's make this a little bit more clear. For example, in this example, we are imaging a brain parenchyma with an area of infarct. So, let's say, for example, we used a B0, a B500, and a B1000 image to calculate our ADC map. In this image, we have an example of the behavior of CSF, which is represented in blue, the behavior of the infarcted tissues, which is represented in red, and the behavior of the normal cerebral parenchyma. If we note here, we will recognize that there is a steep decrease in the B value, or the logarithmic B signal, with increasing B value. This means that it will give us a steep logarithmic curve for the CSF signal plotted over increasing B values. This steep slope is represented as a large ADC value within the image. So let's go to normal parenchyma. Here the slope is neither steep nor shallow, so it will give us an intermediate B value if we take the average of this curve, or the logarithmic value of this curve over time. Let's go to our infarcted tissue. The infarcted tissue represents only a slight decrease in signal over increasing B values. This slight decrease represents a shallow slope of the curve and will thus give us a low ADC value. Here, as we said in our example, the ADC map was calculated from a low B value image, which was the 0 or the T2 weighted image, and another higher ADC or B value, which was the B1000 diffusion weighting. We can use this either with another value in the middle, such as B500, or just using the 0 and the 1000 to calculate the slope of this curve. And the slope of this curve represents our ADC value. So let's see an example of how the images appear. This is the diffusion weighted imaging of the brain in a normal pediatric patient. The B0 value, or the B0 image, as we have previously discussed, does not contain any diffusion weighting. This means that it will appear closest to a T2 weighted image. The B1000 value will have high diffusion weighting with minimal T2 effects, thus it will appear like this. So, ADC map, as we just discussed, is not a true image. However, it is a mathematical calculation, and it will only represent the amount of diffusion within the tissue. So here, since the logarithmic curve is steep within the CSF, it gives us a high ADC. And also, the sulci of the brain parenchyma will give us high ADC because it contains CSF. However, the brain parenchyma gives us an intermediate or gray signal intensity because it is returning an intermediate ADC value. Okay, let's say that we have an area of infarction here. This area of infarction will show us a slope curve, thus will give us a low ADC value. So any area of infarction here will appear hypodense or relatively black in comparison to the surrounding intermediate signal intensity brain parenchyma. So how do we interpret DWI? Let's have a look at some examples. Here we have a diffusion restriction or a true diffusion restriction, which normally appears as a high value on high B1000 images and appears low on the ADC due to the small slope of the infarcted tissues. This is actually a true diffusion restriction. True diffusion restriction usually appears high on T2 weighted images, high on DWI, and low on ADC. So, some misinterpretation can occur in this case because we have some artifacts occurring from B weighted images. What type of artifact can we encounter during the interpretation of a DWI? The first and most common artifact is the T2 shine-through effect. This is a hyperintensity on DWI images because of intrinsically high T2 weighting. Since the ADC map removes the effects of T2 signal, any region that has a low signal on ADC is a true restriction. The T2 shine-through effect usually occurs when there is a subacute or chronic infarction. Let's see an example to make this clearer. Here we have an example of T2 shine-through. This is a small area of subacute or chronic infarct which appears high on the T2 weighted images and also appears artifactually high on the B1000 image. Why does this area appear restricted on the B1000 images despite not being a true area of the restriction or an acute infarct? This occurs because the T2 high signal shines through or is superimposed on the B1000 images due to the persistent T2 effect within the B value image. However, when we go to our ADC, we do not find this high signal within the ADC map. Why? Because the ADC map is a true reflection of the amount of diffusion within the tissue. And here we find that this amount of diffusion is almost equal to the regular plain parenchyma. So this is not an area of true diffusion restriction, and it is just the effect of the T2 shine through. Let's take another example of artifact. T2 blackout. The T2 blackout occurs due to a hypointensity in the DWI image because of intrinsically low T2. Using the same principle of T2 shine through, the low T2 weighted images which appear here as a rim surrounding this lesion, which appears dark on T2 weighted images, remains persistently dark on B1000 images, and on ADC is neither dark nor bright. Small area of brightness, small area of darkness, so it can be iso, dark, or high according to the slope of the curve within this tissue. The cause of T2 blackout is because predominantly of susceptibility weighted effects, and susceptibility weighted effects occur due to the paramagnetic effect of hemoglobin and its components, and this occurs in any hematoma. So when we are imaging a hematoma, diffusion weighted imaging has limited value due to the presence of T2 blackout. T2 blackout occurs mainly due to susceptibility weighting effect, which is due to the paramagnetic effect of hemoglobin within the blood. So this will give us a low signal on T2 weighted image, a low signal on B1000 image, and will give us a low or iso or high intense signal according to the slope of the blood calculated during the ADC map calculation. So the last one, which may occur in some cases, is the T2 washout. What does T2 washout mean? It means that we will see an iso-intense signal on DWI, neither restricted, high, or facilitated low on B-weighted 1000 images. Why does this occur? This occurs due to some balance or equilibrium between T2 weighted images and ADC maps. So we previously mentioned that in ADC map, anything which appears high signal or has a steep slope has a facilitated or free movement of water particles, such as CSF or areas with limited cellularity. So in this low cellularity tumor, we have an high ADC due to the steep slope giving a high signal on ADC. We also have this high signal on T2 weighted image due to the increased T2 relaxation, which more or less negate each other and appear as an iso-intense signal on the B1000 images. And this commonly occurs, as we just mentioned, in areas of facilitated diffusion such as vasogenic edema, low cellularity tumor, and possibly in CSF if both the B2 values and ADC values are equilibriized. So let's revise how to clinically interpret diffusion-weighted image. Here, when we have diffusion-weighted images, we have to see our signal characteristics in at least 2 separate images, if not 3. The 3 images that we need to interpret diffusion-weighted images are the T2 weighted image, which is the equivalent of a B0 image, the diffusion weighted image, which is usually an intermediate or high B value image, which, as we just mentioned, but as a reminder, has a combination of T2 weighted and diffusion weighted effects, and the ADC map, which only represents the amount of diffusion within the tissues. So, if we have a restricted diffusion, as in this first example, this restricted diffusion will appear high on T2 weighted image, high on B1000 image or high B value image, and low on ADC. Since this high signal on T2 weighted image and high B value image appeared low on ADC, this is an actual true diffusion restriction. Let's see our second example, which is T2 shine through. For example, if we have a lesion which appears high on B0 image, which is the equivalent of T2 weighted image, and high on high B value image, such as B1000 image, but does not appear or appears iso-intense on ADC map. So when we have a high image on B0, B1000, which does not appear on ADC, this means that is an artifactual diffusion restriction which appears as a T2 shine through. This appears high on DWI image, high on T2 or B0 value image, but it will appear iso-intense on the ADC map. Let's see our third example, which is an example of accelerated diffusion. As we see here, there is a bifrontal extraaxial CSF fluid accumulation. Let's see, it will appear high on the T2 weighted image. It will appear low or iso-intense on the B1000 image, and also appears high on ADC image. And as we have just discussed, the high signal on ADC image here in areas with facilitation is due to the steep curve or the steep logarithmic curve of the CSF. So this is actually a prominent extraaxial CSF space. As we see here, it is low or iso-intense on the diffusion weighted image. It is high or iso-intense on the T2 weighted image, and it is also high on the diffusion or ADC map. Our last example is an example of T2 dark through, which appears of low signal intensity on T2 weighted image, low signal intensity on B1000 image, and also low signal intensity on ADC image. In some cases, it can appear iso-intense, and this is also representative of a T2 dark through. Let's come to our last part of this presentation, which is the diffusion tensor image. As we mentioned in the beginning of this lecture, we have an isotropic diffusion, which can be facilitated or restricted, and we have anisotropic diffusion. The diffusion tensor imaging is an MRI technique that utilizes the anisotropic diffusion present within axonal tissues or white matter of the brain to delineate the normal fiber tracts. DTI uses the same principle as DWI, but instead of applying diffusion gradients within a single voxel, which needs only 3 spatial directions, we apply our diffusion gradients in many more directions, usually minimum of 12, up to 24 directions and maybe more, to delineate all the fiber tracts. So in order to delineate all the directions within the region of interest, we will need many more diffusion gradients in many more directions. The generated images from the diffusion tensor imaging, and these are only the main generated imaging, we have other parameters, but it is beyond the scope of this lecture. We have fractional anisotropy map, and this is representative of the degree of asymmetry or the degree of directionality of this diffusion, where 0 is isotropic, where diffusion can occur equally in all directions, and 1 is extremely anisotropic, where the majority of the diffusion only occurs in one direction. This is a grayscale image, and the degree of directionality is represented by the intensity of the signal. So here we have an increasingly directional signal closer to 1, and in the lower signal intensity areas, the directionality is closer to 0. So we have seen the fractional anisotropy map and how it is represented on the image. Let's go to the principal diffusion direction map, which is otherwise called the eigenvector map. And the eigenvector map means the eigenvector is the principal diffusion direction. So this also measures anisotropy and direction of diffusion. But here the direction is color-coded, so we know the direction of each fiber exactly. So in this image, the red fibers represents the transverse direction or the x-axis direction. The green fibers represent the anteroposterior or the y direction. And the blue fibers, which are seen in cross-section here, actually represent the craniocaudal or the caudocranial direction. And here, the degree of anisotropy represents the brightness of the color within the image, and the direction is represented by the color as we have just discussed. The last part of diffusion tensor imaging is, what if we plot these directions and these maps but in a 3D fashion? The 3D reconstruction of the directional map can assess neural tracts and can also assess any surrounding lesion such as tumor and abscess, and from here we can actually plot which nerve fibers appear to be displaced and which nerve fibers appear to be disrupted. So this data collection can be done from the diffusion tensor images. However, fiber tracking is done in a 3D fashion using automatic fiber track software to actually plot this direction and these nerve fibers, but in a 3-dimensional manner. And here the red represents the left to right direction, the green fibers represent the anteroposterior direction, and the blue fibers represent the inferior to superior or caudocranial direction. At the end of this presentation, I would like to thank you all for this attention and see you in the next part.